Yeah, so at this meeting as well, we were reporting an analysis of the 111 patients treated in the JULIET trial. And this was a group of experts that got together, including some experts from the JULIET trial and some outside experts like myself who did not actually treat patients on the JULIET trial. And we retrospectively regraded all the patients using the Lee criteria and the ASBMT criteria and in comparison to the Penn criteria. One of the complications of looking at cross trials between axicabtagene ciloleucel, lisocabtagene maraleucel, and tisagenlecleucel, looking at those results is that they're often using different grading systems. And the early trial, the JULIET trial, which was one of the earliest trials, used the Penn grading system, and the Penn grading is not exactly identical to Lee. And so we wanted to just see, could we regrade the JULIET trial into Lee criteria? And the bottom line is we could. And in many cases, the grading was downgraded for the more serious disease, serious risks of CRS and grade 3, 4. It was largely the same, but a lot of things were downgraded. So it just set the stage for that. And then the second thing we did at this meeting, we also looked at the impact of age for patients who are older than 65 in the JULIET trial, and the impact of different lymphodepleting regimens, and the impact on CRS or neurologic toxicity. And what we basically showed was that age did not really play a huge role. So there were about 25 patients who were older than 65, and their CRS and toxicity outcomes were essentially the same as the younger patients, even though their characteristics were a little bit different. The younger patients had more likely failed high-dose therapy and autologous transplant, whereas obviously that's not as common in older patients. So that was the one major finding. The other major finding was that the JULIET trial was one of the only trials that used variable amounts of lymphodepleting chemotherapy. So they used flu-cy, a lower dose of flu-cy, but they also used bendamustine, and there were a small group of patients that didn't receive any lymphodepleting chemotherapy if they had low counts to begin with. And the impact of CRS and neurologic toxicity was really the same across those groups. So those are the two major findings.